Hello, everybody. Welcome to the Ohio Program for Campus Safety and Mental Health webinar. We very much appreciate you all joining. My name is Russell Spieth. I'll kind of get it started and then I'll move it over to Jessica. As a reminder, we are constantly trying to elicit feedback about how to make these webinars the most beneficial for you all. So we appreciate all the feedback that you have given, and we have tried to incorporate those suggestions into all the webinars we've been doing. And again, thank you all so much for joining.
Thank you all for joining us. As Russell said, my name is Jessica Zavala, and I have the pleasure today of introducing both of our presenters. And so first I'll start with Dr. Lisa Santag-Padilla. Lisa Santag-Padilla is a behavioral and social scientist at the RAND Corporation. She has expertise in child and adolescent health and development, maternal child health, and mental health considerations from birth to college. In addition to her content expertise, Dr. Santag-Padilla has extensive experience with quantitative and qualitative approaches to analysis, large state, regional, and statewide program evaluation, strategic planning, and survey design and implementation. For over 5 years, she co-led with a statewide multi-site evaluation of mental health programs and system initiatives across California's public higher education campuses for California's Mental Health Services Authority, which resulted in multiple peer-reviewed publications and also high visibility discussions around the role of campus climate in students' mental health and service utilization, which we're going to hear more about today. Santag-Padilla's research has appeared in top-tier peer-reviewed journals and has been presented at nationally and internationally recognized peer-reviewed conferences. She earned her PhD in developmental psychology from the University of Florida in 2009 and completed her postdoctoral training in primary care research at Cincinnati Children's Hospital Medical Center. So some connection to Ohio there. And now on to Dr. Michael S. Dunbar. Michael Dunbar is a clinical and health psychologist and behavioral scientist at RAND Corporation. His research examines the ways in which health policies and other contextual factors affect patterns of mental health symptoms, substance use, and treatment utilization. He has expertise in ecological, momentary assessment, survey design, and mixed methods research. Dr. Dunbar has co-led multiple local, state, and national evaluations of programs designed to increase access to behavioral health services. In addition, he was an investigator on the statewide, multi-state evaluation of mental programs and system initiatives across California's public higher education campuses, and also sponsored by California's Mental Health Services Authority. Dunbar's research has been published also in a wide range of top peer-reviewed journals, and his work has also been featured in national and international media outlets such as USA Today, CNN, and The Guardian. He received his PhD in clinical and biological health psychology from the University of Pittsburgh and completed his clinical residency in behavioral health medicine and neuropsychology at the University of Washington School of Medicine. So without further ado, we'll turn it over to Dr. Santag-Padilla and Dr. Dunbar.
Hi everyone, again, my name is Lisa Santag-Padilla from the RAND Corporation. I'll be presenting today along with my RAND colleague, Dr. Michael Dunbar, on a collective effort that both he and I have been a part of for a number of years at RAND that examined the mental health climate of college campuses in California. And before we get started today, I did want to provide you with a little bit of background about RAND for those of you not familiar with our organization. So RAND is a nonprofit research organization based in Santa Monica, California, that has campuses elsewhere, and it aims at improving policy and decision-making through research and analysis. The RAND's work includes a mix of grants and contracts and spans a broad range of policy issues and clients around the world. Now, these issues are informed by diverse research methods and are often tailored to meet the specific needs of the project or the client. RAND researchers, such as ourselves, often work side by side with decision makers, and throughout all of our efforts, we do apply the highest standards for scientific rigor and objectivity to ensure our findings and policy recommendations are not only objective, but are also reliable and practical. These same standards were applied on all of our work on college mental health in California. So before we get started, I'd like to highlight 3 objectives for today's presentation on slide 2. First, you will learn about different methods for evaluating student mental health issues on college campuses. Second, you'll gain a better understanding of the connection between campus climate, peer support, and mental health service utilization among college students. And third, you'll learn about the societal benefit of increasing access to and engagement in mental health services for college students. Moving on to slide 3, among college and university students in the United States, there is a substantial gap between the need for mental health treatment and the receipt of mental health services. Now, recent studies estimate that somewhere between 20% to 36% of college students deal with some form of serious psychological distress. However, only approximately 1/3 of these students, many of whom have access to on-campus providers and insurance to cover services, ever receive treatment. As we note on slide 4, this unmet need for mental health care among college students represents a significant public health issue. Young adulthood is a critical period. Without treatment for mental health problems, students face a range of potentially serious and lasting consequences. Now, these may include problems with academic achievement and dropping out, as well as substance use, difficulties with social relationships, and possible employment difficulties such as lower lifetime earning potential. As part of California's Mental Health Services Act, or Prop 63, the California Mental Health Services Authority, or CalMESA, began funding statewide mental health prevention and early intervention efforts for higher education. Now, these efforts included a range of specific activities such as training and education interventions for students as well as faculty and staff, informational campaigns on campuses, and mental health helplines. One segment of this work specifically aimed to improve mental health and well-being among students in California's 3 public higher education systems. This included the University of California, or as we'll call them UC, California State Universities, or CSU, and California Community Colleges, or CCC. Now, today we're going to spend most of our time reviewing the evaluation work that RAND conducted on student mental health within these 3 systems. So as you'll see on slide 7, California's public higher education system serves nearly 3 million students. However, there is no single coordinating body. Instead, the 3 systems operate independently with slightly different governance structures. And of note, CSU is the largest university system in the U.S., serving nearly 500,000 students. And CCC, with over 2 million students, is the largest higher education system in the nation. Now, critically, the systems also differ with respect to availability of on-campus mental health clinics. Although UC and CSU, which are the university systems, have a system-wide network of on-campus clinics, CCC, or the community colleges, their campuses vary with respect to availability of on-campus mental health services. On slide 8, we provide some information to help you contextualize some of these key findings that we're going to review today. So to potentially tee up some discussion later on surrounding considerations for Ohio, we thought it might be helpful to highlight some distinctions between the higher education systems in California and Ohio. So as I mentioned, unlike Ohio, California does not have a state-level coordinating body for public higher education. This has some complexities surrounding coordinating broader efforts involving all public higher education institutions. Now, the 2 states also differ with respect to size, as many of you know, the number of students served, and the student characteristics. So for example, whereas less than 40% of California higher education students attend a 4-year institution, Nearly 2/3 of Ohio students do so. Similarly, nearly 80% of Ohio higher education students live on campus, whereas fewer do in California. These factors have some implications for some of the strategies and findings we'll present today that translate to potential efforts in Ohio. Moving to slide 9, as we touched on earlier, part of CalMesa's efforts were directed toward improving mental health and well-being for higher education students. So specifically, CalMesa focused heavily on fostering campus environments that were more supportive of mental health to help students increase student comfort with using mental health services and to empower students and faculty to better support students with mental health needs. So for instance, CalMesa supported campus information gathering activities to assess the extent of campus mental health problems, things like service utilization, and also perceptions of campus mental health climates, among other factors. In addition, CalMesa sponsored a range of prevention and early intervention activities on campuses. This included activities such as mental health gatekeeper training for students and staff, social media and information campaigns aimed at reducing stigma and also encouraging healthy behaviors, and also bolstering support for peer-based mental health organizations such as Active Mind. So I'm now going to turn things over to Mike, who will walk us through our evaluation efforts in California.
All right, thanks, Lisa. So moving on to slide 10 now. I'll shift our discussion into our collective findings that were part of the evaluation of CalMesa's Prevention and Early Intervention, or PEI, initiatives within California's higher ed system, for which RAND was contracted to serve as lead evaluator. And on to slide 11. So RAND's evaluation of CalMesa's PEI initiatives within the higher ed system was multifaceted. So a key goal of this work was to take the temperature, so to speak, of the mental health needs of college students across the 3 public higher ed systems. As part of this, we aim to characterize the impact of individual and college level factors on a range of factors, including students' utilization of mental health services. So for the purposes of today's talk, we'll specifically focus on things like utilization of on-campus mental health services, as well as off-campus or community-based services, the role of the campus climate around supporting student mental health needs, the role of faculty and staff in addressing student mental health needs, and finally, the potential for emerging technologies such as online mental health services to help address treatment gaps. So on slide 12, I'll present some details of our approach for phase 1 of the evaluation. So briefly, undergraduate and graduate students, as well as faculty and staff, completed an anonymous online survey here. Students and faculty or staff from 32 campuses across all 3 California higher ed systems participated in the study. The survey that we fielded took approximately 10 minutes for students to complete and less than 5 minutes for faculty and staff to complete. The surveys were conducted at 3 different time points. The first 2 waves of the survey were fielded in 2013 and a year later in 2014 for all 3 systems. And then in spring of 2017, we fielded a 3rd wave of the survey among community colleges only. Collectively, through these efforts, we surveyed nearly 60,000 students and 12,500 faculty or staff members. I'll note that because the surveys were not truly longitudinal in nature, that is, where you follow the same individuals over time for repeated measures, there was likely a mix of repeat surveys as well as new survey participants that entered in each wave. So I'll discuss some of the implications of these approaches later on in the presentation. For now, moving on to slide 13, diving into the methods a bit more. So we relied on a variety of approaches to help facilitate implementation of the survey and our data collection efforts. So first, and I really can't stress this strongly enough, we relied heavily on what we refer to as campus-level champions to ensure the success of this effort. So these are individuals who could rally support for the survey effort within the campus setting and essentially be a familiar face or a voice to decision makers regarding how to implement the survey Strong buy-in from these campus champions was really a critical component of this survey effort. So with the help of the Chancellor's Office for the UC and CSU systems, as well as the President's Office for California Community Colleges, college representatives sent email invitations to faculty and staff, as well as students. These messages included a website link to the survey. To help the campus level champions in facilitating this effort, we created scripted email invitations and also developed an email distribution schedule that was specific to each participating campus. Campus representatives were then instructed to invite a large number of students, as well as faculty or staff on their campuses to participate. In many cases, this involved sending email blasts to full campus listservs. These email invitations were sent weekly, on average for about 4 to 6 weeks of an open field period, during which time we monitored the volume of incoming completed surveys. Finally, we used a cash incentive to help facilitate participation and increase response rates. Invited students had the opportunity here to participate in a sweepstakes, either by filling out an index card and sending it to RAND, or submitting their contact information at the end of the survey to participate here. 2 sweepstakes participants were randomly selected from each system, and those individuals were offered a $500 cash prize. I note that response rates varied considerably across both surveys as well as specific campuses. Overall, response rates were relatively low, so approximately 6% for the student survey and between 10 and 20% for the faculty or staff survey. Now, this is typical for an anonymous online survey with this type of incentive structure. But it is something that we take into account. I don't know that all survey analyses here were weighted to account for potential non-response bias. So in the next few slides, I'll present some high-level takeaways from our phase 1 evaluation. For a more detailed overview of the methods and results here, I'll recommend that you refer to the specific research articles that are included at the bottom of these slides. Okay, so moving on to slide 14 now. So based on the findings from the 2013 and 2014 surveys, we found the percentage of California college students that received mental health treatment for mental health issues increased by about 13% across years. So in other words, estimates suggest that compared to 2013, 23,806 additional students used mental health services in 2014 on those campuses that received CalMesa funding. This 13% increase in reported treatment use was estimated to correspond to increases in retention and graduation rates. So based on our estimates, posited there would be an additional 329 graduates in 2014 as a result of increased mental health service use. I'll note that RAND's evaluation of CalMesa's PEI activities was not initiated until after the programs had already been funded and initiated. As such, it's important to keep in mind that there's no true pre-intervention baseline here. With respect to return on investments, cost analyses conducted by the RAND team estimated approximately a $6.49 yield for every dollar invested by CalMesa in higher ed. In community colleges, which tend to experience greater need for mental health services and also have fewer on-campus mental health resources, analyses suggested approximately $11.39 yield for every dollar invested by CalMesa in the community colleges. So in total, an estimated net societal benefit of about $56.1 million. So these results suggest that at a macro level, these investments in mental health prevention and early intervention initiatives may increase not only treatment utilization, but could also potentially improve school outcomes and ultimately lead to large-scale societal benefits. So shifting to slide 15 now, I'll drill down to some of the factors that could be associated with driving these effects at the campus level. So in related work here, RAND evaluated the perceived campus climates and utilization of mental health services both on and off campus. Based on results from our 2013 survey, we found that campuses that were perceived to be more supportive of mental health issues rather than stigmatizing, students attending those campuses were over 20% more likely to seek treatment overall, and over 60% more likely to do so on campus. And this suggests that efforts to improve campus mental health climate could potentially contribute to increases in treatment utilization on those campuses. Moving to slide 16. Just a little background. Colleges and universities have assumed an increasingly important role in addressing student mental health needs in recent years. Given the unique nature of the campus environment, faculty and staff who regularly interact with students may be well positioned to help assist in prevention activities for individuals with potential mental health problems. For instance, faculty and staff could be instrumental in identifying at-risk behaviors in students, in educating students about mental health issues, or in combating stigma associated with mental illness on their campuses. They could also help students who may need additional help by connecting those individuals to appropriate mental health resources. In examining helping behaviors and attitudes among faculty and staff members as part of the survey, we found that most of these individuals endorsed being concerned about or invested in the mental health needs of their students on campuses. And many reported taking action to actually intervene and help students with mental health needs. For example, we found that 69% of faculty or staff reported talking to a student about mental health problems in the past 6 months. And over 70% felt confident in their abilities to refer students with mental health needs to appropriate resources. Just over half of faculty and staff surveyed reported that their campuses at that time were actively putting into place training programs to help them to better recognize and respond to students with mental health needs. However, only about a quarter, 25% of faculty and staff reported participating in those trainings. And only about 41% felt confident in their ability to help students address mental health issues by having those direct conversations. So overall, these findings suggest that faculty and staff on college campuses are aware, open, and interested in finding ways to help support students and their mental health needs. But there may be some limitations with respect to engagement in training or availability of those trainings that could potentially limit opportunities for faculty and staff to serve as gatekeepers for students in need of mental health services on campus. Moving to slide 17 now. So as we touched on earlier, community college students may experience some unique challenges with accessing mental health services. These could be related to, among other things, the fact that many community colleges may not have resources to provide on-campus services to their students. In the third wave of the survey, there was specific interest among community college stakeholders in assessing novel approaches to increasing access to services among individuals who may have difficulties accessing traditional in-person services on campus, for example. In recent years, online or telemental health services have gained increased attention as a potential way to help reduce some barriers to accessing in-person mental health treatment by offering some of those supports remotely. Because these platforms are still relatively new, we wanted to examine students' attitudes and use of these novel services, in particular among individuals who endured psychological distress and could potentially benefit from accessing mental health treatment. So again, in this third wave of the survey, we found that a majority of community college students were open to using online mental health services at some point in the future. That said, very few, in fact, only 3% reported ever having used those types of services. I'll note that in this study, we weren't able to differentiate between specific platforms or types of online services, but overall, these findings suggest that for these services to potentially make a dent in unmet mental health treatment need moving forward, targeted outreach efforts might be needed to help increase awareness and use of particular kinds of online services. So moving on to slide 18 now, I'll pass the ball back to Lisa, who will walk through some of our recent work examining campus peer-based mental health organizations.
Thanks, Mike. So we're now on slide 19. Just to give you a bit of background, student peers and social networks can play an instrumental role in supporting mental health and also facilitating their likelihood to help themselves. Now, student peer-based organizations on college and university campuses, such as Active Minds or the National Alliance on Mental Illness, or NAMI, on campus, and To Write Love on Her Arms, just as some examples, are organizations that are uniquely positioned to have direct and immediate effects on students' perceptions of mental health issues and also their associated stigma. Now, these types of student peer-led organizations conduct a wide range of activities. These activities are aimed at improving student attitudes as well as their knowledge regarding mental health. In addition, these organizations tend to engage in activities that may bolster peer-to-peer support for students with mental health needs. Now, by maintaining a long-term, consistent presence on campuses, organizations such as these can enhance the campus climate for students with mental health problems, and in turn, potentially increase their use of mental health services. However, at the time we were doing this work, and I think it's still the case, there are very few studies that have actually examined the impact of these organizations or these types of peer organizations on college campuses. So moving to slide 20, to address this gap in the evaluation literature, we examined the association between engagement with active minds and changes in perceived knowledge, stigma, and helping behaviors related to mental health. Now, to give you some context, this was part of our larger evaluation of CalMESA's prevention and early intervention initiative. And as part of their statewide efforts, CalMESA provided funds to support and expand the activities and enhance technical assistance for California-based chapters of Active Minds. Now, for those of you who are not familiar with Active Minds, this organization is the oldest national nonprofit organization that aims at empowering students to speak openly about mental health. It was established in 2003 and now has more than 400 student-run chapters on college, university, and high school campuses throughout the U.S. Now, this includes 24 Active Minds chapters on Ohio's college campuses. Student members of Active Minds work to promote a dialogue around issues of mental health and to educate the entire campus and student body about available mental health resources, both on campuses and around the community. To date, our study is the largest study of the impact of Active Minds. In the next few slides, I'll walk through our methods for the study, much the way we did for phase 1 of our CalMESA work. And just to note, this work was published recently, just in the last year, in the Journal of the American Academy of Child and Adolescent Psychiatry. To assess the impact of engagement with Active Minds, we administered a confidential online survey where we followed up with the same students across 12 campuses during 3 time points during the 2016-2017 academic year. Now, ultimately, our goal was to recruit students who were going to become, who were likely to become involved with Active Minds at the beginning of the academic year, and those who also were likely to have little or no knowledge or exposure to Active Minds. After initial recruitment, the RAND Corporation used email and text messages to communicate with the first wave of survey participants about participating in the subsequent second and third waves. Now, similar to our work in phase 1, we relied heavily on the collaboration and support of on-campus champions. And for this study, we partnered with Active Minds at the national level, who then connected us with student fellows on each of the campuses. And these Active Minds fellows, in turn, recruited students using a combination of in-person approaches. And then these include things such as, Active Minds run student union tables, Active Minds events, as well as some in-person recruitment via on-campus courses and other student organization meetings. In addition to these in-person approaches, we also utilize online strategies such as email listservs and targeted Facebook pages. To help incentivize participation, students were offered Amazon e-gift cards with a $5, $10, and $15 structure for each wave subsequently. Overall, collectively, these efforts produced a very strong retention rate. We retained 76% of our participants across all 3 waves of the study. Moving to slide 22, we focused our evaluation on 3 key sets of outcomes. We focused on these outcomes as they're central to the work of Active Minds, but also because they're likely related to improving overall perceptions of campus climate, which we know from our prior work is associated with higher rates of mental health service utilization. So specifically, we focused on students' self-reported knowledge and skills as it relates to identifying signs of mental illness, resources for mental health support, and confidence in being able to discuss mental health issues with a friend. We also examined self-reported mental health stigma and students' self-reported helping behaviors when interacting with a peer who shows signs of psychological distress or suicidal ideation. This last one included things like providing emotional support, helping someone seek professional help, or possibly connecting them with campus or community resources or support. On slide 23, you can see that we had 1,129 students participate in our study. Now, 66% identified as female, and the sample was also ethnically diverse, with approximately 80% identified as racial ethnic minorities, which is consistent with other work that we've done and others do in California. We use latent profile analysis to examine or to empirically determine what we refer to as different student engagement groups, using information about the extent to which students were familiar with Active Minds and the extent to which they were involved with Active Minds at baseline. So baseline, most students fell into this low engagement group. So very little knowledge about Active Minds, very little or to no involvement or familiarity with Active Minds. And fewer students were in the moderate engagement or high engagement group. So generally, familiarity and involvement did increase across the academic year, although not everyone changed at the same rate. Individuals in the low and moderate baseline engagement groups showed greater variability in changes over time, whereas those in the high engagement group tended to show more stability. So meaning that students who were highly engaged at the beginning of the academic year tended to stay this way. Moving to slide 24, to examine the impact of involvement and familiarity with Active Minds on changes in students' perceived knowledge, attitudes, and behaviors as it related to student mental health, we performed a fixed effects analysis of longitudinal panel data. Now, this approach allowed us to control for not only the effects of within-person time invariant confounding factors, so these included things like socioeconomic status, geographic origin, things that we did not expect to change over time. We also were able to control for potentially confounding observed variables or things that we measured that can change over time, such as personal experience with mental health problems. Note that we expected these effects to vary systematically depending on the extent to which students were engaged with Active Minds. So we also stratified our analyses to look at these longitudinal associations separately within each of the three engagement groups. Now, our findings showed that becoming more familiar with Active Minds was associated with increased perceived knowledge of mental illness signs, supports, and resources. And it was associated with a decrease in stigma of mental illness over the course of the year. So this was actually the case even among those students who were not directly involved with Active Minds. So simply being familiar with Active Minds was associated with these positive changes within one academic year. Additionally, becoming more involved in Active Minds was associated with the following: increased perceived knowledge of mental health issues, increased likelihood to intervene if they saw someone experiencing significant emotional distress or thoughts of suicide, and also increased helping behavior. So when interacting with someone with a mental health problem, that they actually did engage in helping behaviors. Moving to slide 25 now, ensuring access to high quality mental health services is a key component to reducing unmet mental health need among students. Now, as we mentioned earlier on, many campuses we examined, including all of the UC and CSU campuses, have on-campus services, which in many settings are available to students at little or no cost. Yet, even on those campuses, many students don't access available treatments in times of need. Now, our findings suggest that efforts to improve factors such as campus climate toward mental health and stigma surrounding mental health service use may help to increase utilization of services when they are available. In addition, both peers and campus faculty or staff members can play an important role in intervening and linking students to the appropriate resources. So efforts to support both faculty and staff and students in these roles, for example, through training and education programs or sponsoring peer-based activities, these kinds of efforts could pay dividends with respect to fostering campus environments that are more supportive of student mental health. However, limitations in training engagement and availability in training could potentially diminish the important opportunity for faculty and possibly students to serve as gatekeepers between students and needed services on campus. So we do want to note that continued efforts are needed to ensure that faculty, staff, and peers are equipped to address student mental health issues when the need is there. On slide 26, overall, findings from this series of studies suggest a few promising options that universities and colleges can consider when thinking about ways to improve student mental health and well-being on their campuses. Now, these things include, but are not limited to, supporting and enhancing the presence and profile of peer-led mental health organizations on campuses, engaging with key stakeholders and other partners, including community-based mental health organizations, on efforts to foster campus climates that are supportive of student mental health. And this may be particularly important for campuses with limited resources, including those that don't have existing on-campus mental health services. Another approach may be developing coordinated messaging to reduce stigma and increase awareness of service resources among students and faculty. So I want to now pass the presentation back to Mike, who will discuss some of our key limitations and takeaways for the higher education systems and wrap up our presentation.
All right, thanks, Lisa. So we're on slide 27 now. So just as an important note here, as with all studies, it's important to consider the findings that we presented today in the context of some key limitations. So first off, these studies all used convenience samples among participating college campuses. Although all of our analyses used weighting to make our sample sort of better represent each campus's general student body and address potential selection bias, we weren't able to assess whether or to what extent respondents might have differed from non-responders, including campuses that didn't participate. In addition, the data here were all self-reported. So we don't have any reason to believe that students or faculty inaccurately reported or misrepresented things like service use or other factors, but it is important to note that we didn't examine data on actual service use records. The studies here were also designed to address really specific evaluation questions, in part surrounding the mental health landscape and service utilization. And this naturally limited our capacity to examine, for example, things like within-person changes in actual mental health outcomes over time. Similarly, all the programs described here involved a wide range of specific components or activities. So things like individual messaging campaigns or specific training programs, and a series of events essentially that occurred in concert. And because of the design of the evaluation, we weren't able to tease apart, in those cases, specific effects of individual components to really get at those active ingredients of a particular program. Finally, as we discussed earlier, California's public higher ed system differs in a number of key ways compared to that in other states. And this has implications for thinking about how some of the findings discussed here, it could potentially generalize to different systems or states or inform evaluations of other programs. So moving on to slide 28 here. So a couple of general takeaways. So when planning for an evaluation along the lines of the ones discussed today, it's really critical to consider these types of issues that I discussed in the previous slide. Broadly, that when planning studies like this, you want to take into account a number of key steps which are often applied to these types of efforts, ranging from sort of the early stages into development. So first, that early information gathering, so things like environmental scans to take the temperature and assess the current landscape are really foundational for identifying key issues or areas of focus and informing sort of what shape the ultimate evaluation might take. Similarly, investing time in clarifying and refining specific questions, goals, and scope of the evaluation are instrumental in ensuring that the evaluation can ultimately achieve its intended goals. So we often find that the structure, process, outcome model here is a really simple and helpful approach in those early stages for helping to develop a clear understanding of how some of the activities that are being implemented might be linked to key outcomes for an evaluation. And this can also help to inform what types of approaches might be most appropriate to take. So for example, considering things like what types of measures or data sources might be most appropriate or helpful in answering some key evaluation questions. Will you collect quantitative data only or qualitative data as well to help provide richer context? What types of measures might you use? As I referenced before, things like self-reports or actual service use records. Is there interest in assessing specific types of mental health or substance use outcomes? Do you want to look at changes over time within individuals, or is a cross-sectional analysis perhaps more appropriate? And things like what types of partnerships or other resources might be needed to help ensure success of the evaluation. All of those things are really critical considerations when thinking through the design of a particular evaluation. And a logic model here can be extremely helpful in organizing and working through some of these issues and planning for ultimate success. So the reference below on this slide provides a really helpful overview of logic models and evaluation planning, and specifically uses this CAMESA evaluation effort as an example. So moving on to slide 29 here. Also important to note, there are many important but unanswered questions surrounding efforts to improve student mental health and well-being in higher ed systems. Just a handful of key areas of future inquiry for our team are things like tailoring outreach and intervention efforts to address the unique needs of diverse student groups. Better understanding the role of emerging technologies like online and mobile service delivery platforms, and how those things might contribute to reducing unmet mental health treatment need on campus. Teasing out or identifying key ingredients or specific components of a program that might drive effects of programs like Active Minds on campus. And finally, understanding how the impact of specific types of programs or initiatives could potentially vary across settings or in relation to pre-existing campus mental health climates before implementing a program on campus. So in other words, are there certain types of prereqs that are required in order for some interventions to make maximum difference on a particular campus? So moving on to slide 30 here. So that brings us to the conclusion of our presentation today. I would like to thank the California Mental Health Services Authority, or CalMESA, for providing support for all of these studies, our RAND colleagues who contributed to the findings that we presented today, as well as our Active Minds collaborators, without whom this work would not have been possible. So for anyone who has questions that are not addressed, follow up on anything else, you can reach us at the following email addresses listed here. And thanks so much, everybody, for attending.
Yes, thank you.
So we'd like to thank you so much, Dr. Santak-Padilla and Dr. Dunbar. We really appreciate that. Just to give you, those of you listening in, a little bit of insight. So in Ohio, there's been some interest, early interest, I would say, in potentially considering statewide or system-wide evaluation. So when we began to hear kind of rumblings about that, that led Jessica and I to kind of look into who had been doing this type of work, which led us pretty quickly to our presenters' work and what they did in California. And we thought that there was some interesting, there's some differences obviously, but some interesting parallels in the states. So we thought it would be first of all, it's been a helpful process just talking with them outside of this presentation, but this presentation also was very informative. So thank you all. So our folks are a little bit quiet right now in terms of questions, but the good news is I have a lot because of conversations I've been having with people. So one, I guess, first off, is how did you all, and I believe I spoke with you a little bit about this on the phone, but it would be helpful for other people to hear, I think. So you had 32 campuses essentially agree upon a survey. Can you tell us a little bit about that process, how you all got buy-in from those, diverse campuses to use a similar instrument?
Sure. So the effort that we were engaged in California was, I don't know if that was necessarily unique, but the context of that. So CalMesa is an umbrella government entity in California, had funding and had been approved to support various prevention and early intervention activities across the state. And so RAND was contracted by them to be the evaluator. Part of that work was also to fund efforts on the higher education systems and their campuses. So from the get-go, they had sort of parallel partners to us on these various systems. So within the chancellor's office and the president's office at the community college level, we already had sort of partners. And so they went out and then they recruited the campuses to participate. They got permission. They knew who those sort of important stakeholders were to get the buy-in, because as we would probably experience in most systems, there was resistance to doing this. So it wasn't just from the beginning, all doors open, sure, come in, let's implement a survey. There are a lot of needs. A lot of leadership was very concerned about the survey fatigue of their students. And so we had to take that into consideration in not only the timing, but the length of our surveys. We had to be very clear on how the information was going to be used, why we were deciding to use sorts of questions. And then as incentive to the campuses, we also delivered back to them a de-identified data set of the data that we collected, so they could walk away and take a closer look at what's happening on their campuses. Because that was not something we controlled for differences across campuses, but we didn't do a campus by campus evaluation. So this was something that was a strong incentive for the campuses to want to participate. You need to be able to give back to them as well.
Yep.
And
just to piggyback off of what Lisa said, so Russell, to your question about sort of how the ultimate final survey was narrowed down and how we got to a point of agreement on the specific items that would be included, that was a highly iterative process. Mm-hmm. So as Lisa mentioned, there were certain content domains that folks came into the eval with, knowing that these were areas of interest that involve stakeholders, and RAND would offer sort of our recommendations in terms of the specific types of items or instruments based on the existing literature that would be appropriate to include, but we were constrained in other cases by a 10-minute survey. It was ultimately what we were shooting for.
Right. And you feel free to stop me if we're going too tangential here, but to use the final survey we did as an example with the community colleges, at that point in time, there was a report that came out from one of the other systems in California noting that food insecurity and housing insecurity was a major issue. And so we had, regular monthly meetings with their team at the president's office level to discuss these issues. They would bring to the table, here's what we are seeing and hearing within our campuses. we want to be able to address this. And so then we would say, great, let's go back to our resources. We're going to connect with our colleagues and the literature and identify the best and most efficient way to assess, what's going on with these, what's happening within these issues on your campuses. And so that was this iterative process we engaged in, and that was representative not only of the work we do with community colleges, but all the college systems as well as the Active Minds work. We never made decisions independently and just said, this is what we're doing. I think that was very important to not only ensure buy-in, but also just to ensure that our effort to sort of take the temperature of what was happening in the state best served the state.
No, super helpful. And we have our good colleague, Dr. Tara Scarborough from the University of Cincinnati. And she was wondering if the survey could be made available to other universities to use. So the survey that you ultimately landed on for the phase 1, I assume, not the Active Minds, would that ever be accessible?
That's a great question, because we have had different entities reach out to us about sort of subsets of questions, and we have been working on and discussing internally within RAND to sort of not necessarily copyright it, but create it in a way that is available for others to use. Now, there may be some updating that needs to happen, obviously, because this was done back in 2013, 2014 as a starting point. But that is something that we have been working on. And so if there's interest, that there may be opportunity there. I will offer too, we're open to discussions too about ways to sort of help provide guidance around using these instruments. So I think, through some of our presentation, our discussion just now, Russell, simply just putting a survey out into the field, depending on how you're implementing it, who's responding, how you're using the data, there are different implications of what that information may mean for your university or your organization. And so we're always open to sort of continued dialogue and potential collaborations around that as well.
And so there's a question from University of South Florida, a research assistant there. It's a two-part question, but I'll start with the first half. Perceptions about the quality of care at university mental health resources is a problem at my location. Did you find anything about people not wanting to utilize services because of a perceived lack of efficacy?
Mike, do you want to talk about that a little bit?
Yeah, so I'll note in at least the third wave of the survey that was fielded among the community colleges only, we did ask about a number of barriers to accessing services, both on and off campus. And perceptions of or concerns about quality of services was among the items that we included in those barriers questions. So I'll refer people, and we didn't talk about this in today's presentation, but I'm happy to provide a reference to the group. So we published some of this data in a fairly recent article that was published in Journal of Adolescent Health, on which I'm the first author there. We can distribute that to the crew after the fact. But I guess to address the question, it is a barrier that is identified among a subset of individuals with respect to concerns about accessing certain types of services. But it's among the other, the full range of barriers that we identified was not among sort of the top tier of challenges that folks endorse. I'm trying to read through the remainder of the question.
Looks like a follow-up question, because we can also see them as well, which is really helpful. So how can campus resources improve their reputation and the extent to which this perceived quality of care barrier is addressed?
Yeah, I think that's an excellent question. And I think some of the issues that we touched on in this presentation surrounding efforts to support, consistent messaging and facilitate appropriate staff trainings for both lay staff members, faculty staff, as well as clinicians that are operating in those environments are all critical. And I think it's sort of not a one-size-fits-all or a single a product of all of those efforts occurring simultaneously.
Yeah, and one of the things that we also heard anecdotally, but I think Mike can speak to this better than I can, but anecdotally through our conversations with stakeholders at the sort of administration level was related to not as many issues of quality of care, but just capacity to serve. They're just not, like, even in the most well-resourced campuses, they just do not have enough resources in terms of staff and hours to address all the needs on campus. And so I think this may speak to the need of having a coordinated effort with administration, potentially community stakeholders, the peer-based organizations, to sort of think through how to build out a toolbox, if you will, of tools to best support students. So campus mental health services are one piece of the puzzle, but as we mentioned, there may be opportunity in these online mental health services or telemental health, as well as this peer-to-peer support. And so I think advocating for that, as well as educating this body on the array of resources available, may not necessarily address, I think, this, what Bristen's question about quality per se, but certainly can help build out this idea of having a toolbox to rely on in needing to identify support.
Thank you so much. We are at time. That was fantastic, really informative, and I'm sure this is the first of many conversations on this topic and what we're trying to do here in Ohio. Dr. Padilla and Dr. Dunbar.
Thank you again for joining us.
Bye. Thank you. Take care.
Thank you.
Thanks.